Good afternoon, everyone, and thank you for joining Let's Talk About Health, a community conversation about an important health topic today. I'm Donna Jacobs, Senior Vice President at the University of Maryland Medical System, and I will moderate today's conversation. Since May is National Stroke Awareness Month, our topic today is stroke and stroke prevention. Stroke is one of the leading causes of death and disability in the U.S., and many times strokes are completely preventable. Here to provide key information on the warning signs of stroke, stroke prevention, the various kinds of stroke, and how to communicate with your healthcare provider when seeking care is Dr. Fermín Barreto. Dr. Barreto is board certified in emergency medicine and medical toxicology. He serves as the Chief Medical Officer at the University of Maryland Upper Chesapeake Health, and he previously served a stint as Clinical Associate Professor for the University of Maryland School of Medicine Department of Emergency Medicine, where he taught both toxicology and emergency medicine to students. Dr. Barreto also currently serves as the Covid-19 Incident Commander for Upper Chesapeake Health. He has published over 25 peer-reviewed publications in medical toxicology and emergency medicine, both in the U.S. and across the globe. In fact, he is a complete expert on stroke, and I don't know if he'll remember this, but when I met him, we were talking about some particularized, specialized programs in stroke care across Maryland. Before I turn this over to Dr. Barreto, just a couple of housekeeping items, if you will. As this conversation proceeds, and we do mean for it to be a conversation, please feel free to type any questions that you might have in the Q&A box. Use the Q&A box and not the chat as we move forward, and Dr. Barreto is happy to address as many of your questions as is possible, as that's the point. If we run out of time today, we will post the questions and answers to those on a website at a later time. You also should know that you'll be able to see these slides as well as review the entire presentation online, and I'll give you information on that later. Dr. Barreto, would you get us started, please?
Thank you, Donna, and thank you for that very kind introduction. And yes, I do remember our first stint as we were campaigning for some regulations that helped us treat stroke patients here in Harford County. I want to first promote the questions in the chat. Being an emergency physician, I probably suffer at some level of ADHD myself. So one of my more enjoyable parts about these talks is really jumping from question to question and really look forward to those as we get near the end of the program. The first part is what I think is a great initiative. It really helps structure the way people can really take charge of their health care, and it's by the initiative called Ask Me 3. What is my main problem? What do I need to do? And why is it important for me to do this? So often when we are in the midst of a medical problem, it could be as minor as a cut, it could be as severe as a stroke. All of it really does center around these three questions and getting this information from the people that are caring for you. It is incumbent upon us as doctors, nurses, pharmacists, healthcare providers to be able to give you those answers. And sometimes we get confused, and I, being a patient myself sometimes, I have forgotten to do this myself. And this is a great structured way to just remember, main problem, what do I need to do, and why is it important for me? Go on to the next slide. So why do we care so much about stroke? Well, there's two organs that we really have a tough time living without, your brain and your heart. And we have done a great job with heart attack education, awareness, but we really need stroke to catch up, and it has been. And these stats, I think, are staggering when you think about them. Every 40 seconds, someone in the U.S. has a stroke. Every 4 minutes, a stroke kills someone. Each year, almost 800,000 people experience a new or repeat stroke. Stroke is the fifth leading cause of death in the U.S. Now, COVID may have changed that a little bit this past year, but still, very high incidence and remains a leading cause of serious long-term disability. And this is an important piece. When it's preventable, when you can manage it, a stroke doesn't have to happen. But when it does, it can cause serious long-term disability. Every minute a stroke goes untreated, 1.9 million brain cells are lost. This is probably one of the most important points. We always said, for every second during a heart attack, that's muscle loss. It is even exponential inside the brain. And the brain has a little bit of it's a little bit more of a difficult time being able to heal itself like the heart. So we do have some challenges there. And look at this bottom bullet. 80% of strokes are actually preventable. And that's why we are here today to talk about that. So what is a stroke? And I'll really simplify it. It's when you don't have enough oxygen to the brain. It can be because a blood vessel is blocked. It can be because it's burst. Whatever the cause, you're not getting enough oxygen to the brain, causing tissue to die, brain tissue to die. And there are two primary types, one that is ischemic and one that is called hemorrhagic. And the important thing to understand between these two is one resembles a lot of what we know about heart attacks. It is essentially plaque that leads to reduced flow to eventually a cutting off of that flow of blood to the brain. It is the more common cause in the heart as well. Hemorrhagic is where the blood vessel actually bursts, and we have the problem of that tissue, brain tissue, not getting enough oxygen, and you also have the problem of blood inside the brain. So we'll talk about both here in just a minute. Ischemic is definitely the most common. The large majority of them, 88%, are this type. And it's either caused by a clot that gets stuck into the blood vessel, or the plaque actually grows to the point where it actually impedes the flow. So you can actually get a clot that comes from somewhere else, called embolic, so it can come from a different part of the body. It has to actually cross over inside the heart and then go into your brain. And then there's thrombotic, which actually can happen inside that artery itself. So causes for this, and this is where we get a little bit into the preventable part. Fatty deposits can line the blood vessel wall. This is the plaque formation, and you can actually get thrombus or clot that forms there. And again, there's the embolic or the embolus, where it actually has to travel for somewhere else to get to that area. Hemorrhagic strokes, thankfully, are the minority of strokes, but there's still a good portion at 12%. And when that blood vessel ruptures, again, blood can fill different parts of the brain. And depending on where it fills, that blood gives the name of that stroke. So subarachnoid means that it's filled, blood is filling into an area surrounding the brain, and intracerebral means that the blood is filling within the brain. And we're not going to try and turn everyone into neurosurgeons and neuroscientists with this. Just trying to give you some general context of the two different types of stroke and where some of these different strokes come from. Some of them, like aneurysms, you're usually born with. So that may not be as preventable per se, although managing your blood pressure does decrease the incidence of this. Something called arteriovenous malformations, or AVMs, are basically a little cluster of blood vessels that lend themselves towards rupturing. So I'm sure there's probably people that know that people have had, the people that have had strokes, or you probably have heard people talk about mini strokes, and that's usually referring to transient ischemic attacks, or TIAs. This is where you actually have symptoms of stroke, but they resolve on their own less than 24 hours. These are important warning signs of stroke. 40% of all people who experience a TIA will go on to have will actually have an actual stroke. So there will actually be brain tissue that has died as a result of the symptoms, but the symptoms actually resolve, but that brain tissue never recovered. So a lot of times when we admit patients, we actually label them as a TIA in the beginning, and actually will end up leaving the hospital with a stroke diagnosis. So within 2 days after a TIA, 5% of people will actually go on to have a stroke. So it really tells you how much of a warning sign it really is. And then within 3 months of a TIA, 10 to 15% will have a stroke. So you see the risk actually go up. So what we're really trying to drive home here, and TIAs can be mild. It can just be numbness in an arm. It can be, transient weakness. All the same symptoms that we're going to talk about with regards to stroke can occur with TIAs. It's just that it's temporary. They occur when blood flow through the brain is briefly blocked or reduced, and then sometimes the TIAs are temporary, but still actually shows the sign of a full-fledged stroke on a CAT scan. Person who has a TIA, as we're trying to drive the point home here, is 9.5 times more likely to have a stroke. So this is a medical emergency. Just because the functionality came back for you may make you think, oh, you know what, I'm okay, there's no problem. No. Make sure you take this warning sign as serious as you would have if you had chest pain, because we have a chance to actually prevent that stroke. So this segues into 80% of all strokes can be prevented with healthy behaviors. Long-term effects of a stroke may be minimized with immediate treatment, and more people are surviving and beating stroke. And this is one of the things I have witnessed firsthand in the emergency department. I will tell you, the treatments have been great, but even more impressive we have seen people either with an initial stroke and then get the risk factor modification, which we're going to get into, actually both improve and we even see improvement in the areas that have been damaged by the stroke. So what we have been able to do, just in these past 10 years has really given us hope to be able to continue to combat stroke and its impact on people's lives. So let's talk about the stroke symptoms. So there's a nice little acronym, and for myself going through med school, acronyms were my best friend. It's an easy way to help you remember things, and this one is B FAST. B is for your balance, I for your eyes, F face, A arms, S speech, and T time. Going through each of these, your balance can be loss of balance, coordination. This can feel like the room spinning, or you have to hang on to a wall. Eyes can be double vision or loss of vision in one eye. The face is often a facial drooping, and it could be just one part of the face near the lips. And usually you use the eyes and the lips as your main areas that you're going to try and provide your bearings there. Arms, definitely weakness, but sometimes it's just numbness, slurred speech or difficulty speech. And when I take a history from someone, sometimes the patient may not even realize their speech has been slurred, but when I talk to a loved one, they say, no, this is not the way they sound. And then time, and this one is extremely important. Even if you are, 10 minutes away from the hospital, it is not safe for you to get into a car to try and drive. You don't know how this is going to progress. You dial 911 immediately. They are trained. They are going to call us when they get there to let us know in advance that we have a possible stroke patient coming in. So I promise you, you are not going to be faster than an ambulance service in getting the timely care that you need. So please call 911 if you develop any of these BFAST symptoms. So other stroke symptoms, and we touched on some of them: sudden numbness or weakness of the leg, confusion or trouble understanding. More often than not, I get the history again from people that were around, the loved ones that live with the patient, and they say suddenly they couldn't remember their name, their date of birth, and were able to kind of piece things together. So it's not even if you're not able to, even if you're not having the stroke, being able to recognize it in someone else, in a loved one, is extremely important. Sudden trouble seeing in one eye or both eyes, trouble walking, dizziness. Again, we went through these, and then a sudden severe headache. This one's a little bit different. This one may make us start thinking about a hemorrhagic stroke or blood inside the brain. When you get a sudden severe headache with no known cause, what we call a thunderclap headache. So keep that one in mind. That one is another sign that you need to seek medical care. What not to do. So do not finish dinner, go back to bed, and say, you know what, this is going to go away. That is the absolute worst thing to do. You're allowing that brain to just continue to die if it is not getting blood flow. Don't wait to see if it gets better. Don't wait for your family member or neighbor to check you out, or ask someone who watches a lot of the ER movies and is a family expert. What you need to do is you call 911. And as I said, the network of stroke care that we have within our state has really just grown incredibly well. And I will tell you, that AMBO crew gets there, the moment they suspect a stroke, they call back to the emergency department. We get that call, and then when we know that this is a suspected stroke patient, we will prioritize that ambulance, prepare the room, prepare the CAT scanner, prepare all the things that we need to be able to assess this patient as fast as possible so that we can determine, number one, have you had a stroke? And number two, do we need to treat it with some of the life-saving medications that we'll talk about? So again, I don't think we can drive this point home enough. Immediately call 911, and we need to know when the time of the symptoms started. And again, this isn't just for you. If you have a loved one that you notice this, I mean, we literally turn into very fast detectives because we have to work quickly to find out when was the onset of symptoms, because dependent on that will determine whether or not we are able to give you treatment. If it is too long, then we know from all the studies that we've done that it is too late, and the brain has gone without oxygen long enough that the damage is irreversible. And we can actually cause harm with the treatment if we give it to patients who have had a stroke for too long of a period of time. So again, we're not just doing this for ourselves, but we're doing this for anyone around us. The sooner a stroke victim gets to the hospital, the sooner they'll get the life-saving treatment. So if you're able, if it were not just yourself, but a loved one that was in the house, you guys are out on a vacation, wherever you may be, you pin down when was the person last known normal. Then if you get to the hospital in time, we are able to provide a clot-busting drug called TPA, or tissue plasminogen activator. No one calls it that. Everyone calls it TPA because that's way too long of a name to be able to say. So that is one of the primary treatments that we have to be able to open up that. Remember, we talked about ischemic strokes, and this is more for ischemic strokes. So this is not for the hemorrhagic where you're already bleeding. So in the ischemic strokes, you have a blood clot that is in the way of the blood to provide oxygen to the brain after that blockage. TPA dissolves that clot and allows that blood to travel through the artery again. And what's really interesting is this is exactly the way we started with heart attacks many years ago before we had stents. We actually gave clot-busting medications so that we could open up the arteries and allow blood and oxygen to get past that area of narrowing. So here's an example of using Ask Me 3. So my blood pressure, my high blood pressure is well controlled with medication, but my mother suffered from a stroke a few years ago. Should I be concerned? Well, what is the actual problem? So in addition to lifestyle choices, heredity does contribute to overall health. And to also add, stroke itself, it is multifactorial. So it is a lot about high blood pressure, obesity, smoking, age. So there are some, now age you don't control. All of us get older each day we wake up. But whether or not we pick up that cigarette, whether or not we exercise, whether or not we take our medications for high blood pressure, those are things that we control. What do I need to do? Continue to take all your medications as prescribed, make choices to ensure your weight and cholesterol are within a healthy range. And why is it important for me to do this? With the help of a healthcare provider, you can modify stroke risk factors that are within your control and can significantly reduce the risk of having a stroke. So, hopefully, if I asked any one of the 100-plus attendees by now, all of you would be able to answer this question. Can you prevent a stroke? And again, the answer is 100% yes. Remember, that's a staggering number to me. We in the hospital, we take care of everyone that comes in through our doors. But it would be wonderful to actually see ourselves with fewer stroke patients because our population is getting healthier. This would be welcome because it means that people aren't being disabled, people aren't dying. You're able to live healthier lives as a result of this. And think about that, 80%. It's just really a staggering number to me. Next slide. So how do you do it? So I touched on some of them, and really none of this is rocket science. You talk about controlling your blood pressure, don't smoke, a low-salt diet, lower your cholesterol, and these last two are actually hand in hand, lose excess weight and stay active. There was one study that showed just by staying active alone, just that alone, and you don't have to be a gym rat to be able to do this. We're talking about walking 1 or 2 miles a day, three times a week, and that alone was able to decrease your stroke risk. And I think the study was somewhere around 25%. And and another study for those that have dogs, people with dogs, because you have to walk the dog, actually ended up with a lower stroke risk, which I thought was fascinating. Go ahead, next slide. So, problem. My wife takes a low-dose aspirin every day to lower the chance of having a heart attack. Is this something I should be taking to prevent a stroke? So, and what is the problem? Aspirin works by stopping platelets from pumping together and forming blood clots. So that is essentially you're preventing the formation of blood clots. It is known to decrease both heart attack or stroke. Not all aspirin are the same. It's usually not more than a low-dose baby aspirin that is needed, but do not do this on your own. The second one is, what do I need to do? Ask your healthcare provider if taking aspirin is right for you. They'll know your medical history. They'll know the other medications you're on. If you're already on some blood thinners, they may not want you on a low-dose aspirin. You may not be at high risk for stroke. Maybe you're too young and you shouldn't be on a daily aspirin a day. So make sure you talk it over with your healthcare provider. And why is this important for me to do? Certain medications may actually lower aspirin's ability to prevent a stroke, so it's really important. And again, even just aspirin itself, being on it, this is not like one and done. You have to stay on it to be able to decrease your overall risk. So is it worth being on that lower dose aspirin for an extended period of time if you're only 30 years old? Probably not. And with no other medical problems. But that's why you want to have those conversations with your provider. So, state of Maryland has been, I think, blessed with a number of high-quality hospitals throughout the state, and we have a stroke statewide system of care. The Maryland Institute of Emergency Medical Service system certifies all of these stroke centers in Maryland. MIMS also governs our ambulance crews and EMS providers throughout the state. Stroke care in Maryland is outlined by state regulations that were passed by the Maryland General Assembly. And if a hospital is not stroke certified by law, EMS must actually bypass that hospital if they're transporting anyone with stroke-like symptoms and take them to the next closest certified stroke center. Now, the one thing, and it's an interesting piece, it's a little bit specific to Harford County, but I thought I'd just share it. But in the coming years, when we go to a freestanding medical facility, we will be able to be called an acute stroke ready center, where we will still be able to administer TPA to those patients and then transfer. So as long as you have the full-fledged emergency department, CAT scan and medications and pharmacy in place, then you're able to administer that medication. But this protocol for EMS, they follow very diligently with regards to taking patients with stroke-like symptoms to the nearest certified stroke center. So I think we landed just about on time, and now look forward to some questions.
This is great. Thank you, Dr. Barreto. And we do have quite a number of questions. But first, before we get into the questions per se, you just mentioned a freestanding medical facility in Harford County. Can you tell us what is an FMF?
Absolutely. So we actually have some freestanding medical facilities in the state of Maryland, and essentially what this is an emergency department that doesn't have inpatient beds attached to it. So for anyone that knows Bowie, or there's one in Eastern Shore and in Queen Anne's County, these are emergency departments that are not attached to a hospital per se. Our freestanding medical facility will actually have some observation beds associated with it as well, and that will be a little bit more unique compared to some of the others. And Laurel Regional is another one that was converted to a freestanding, although during COVID times has actually had to change back. But that is what a freestanding medical facility is, and will look like, here in Harford County.
Thank you. This is great. So you mentioned TPA, and that time is critical. You can only administer TPA within a certain period of time. What is that time frame?
So, whoops. Sorry, I was just given an alert on my computer. So TPA, again, is the clot-busting drug that we have to administer. So the goals that we have, it used to be a lot more clear-cut, so forgive me for a little bit here, because I'm actually going to bring in the conversation of what we call clot retrieval now. So we have TPA, which is one part of it, and then we have the clot retrieval. So the time windows have really become a little bit blurred here. We want to be able to administer TPA within, and you know what, I'm going to blank on, I believe it was 4 hours.
4 hours.
And then for interventional, for the clot retrieval, it was initially 6, expanded to 12, and now we are even taking patients up to 24 hours from the time of stroke symptoms. Now, let me explain what clot retrieval is a little bit. What we can do first, of course, is administration of that TPA, which we can do within 60 minutes of arrival of a patient to the emergency department. But to do that, we have to get the IV line, get the history, understand when the last known normal is, talk to the patient, of course, and get the CAT scan. If everything checks up and lines up and we feel confident that this patient is suffering a stroke, we administer TPA. But if the patient is also a candidate for clot retrieval, where we actually, just the same type of process as a cardiac catheterization, which people may be more familiar with, we actually enter through the artery, not myself, but we would actually have to transfer you to a center that, like the University of Maryland Medical Center, that performs these procedures. And they go through the artery, and instead of fishing the wire towards the heart, they go towards the brain, identifies the artery that is blocked, and actually pulls the clot out mechanically. So it's a very precise, very elegant procedure that essentially removes that clot, and we're doing that now with much more frequency. So it's even more important for people to get to a hospital as fast as possible, and then sometimes we even have to fly you down to the medical center or to a site that actually performs this procedure so that we can get you there in time.
Thank you. I'm looking at the questions as they're coming in, and let me just make a general statement that this may not be the most appropriate setting for us to give individualized responses about people's health care. And if we have time, I will ask some of those, but Dr. Barreto may or may not feel comfortable answering those specific questions. I would like to really try to focus on the more generalized questions as we move forward and make the best use of our time. There are several questions about TIA. I thought that would generate some real interest, and I'll try to group them in a series right now. I won't ask you all at once, but I'll try to just group them. So the question says, I think you mentioned that the symptoms are similar to stroke. How similar? Are they weakened? And does somebody really know and understand that they're experiencing a TIA?
So, great question. And so if you read the medical textbook, it is the same symptoms of stroke. But the hard part really is, and this goes for even stroke symptoms, it is not easy to figure out, and even more so if it was transient in nature. So if you only felt it for 3 hours, you know, I think everybody's probably watched a movie and slept on their arm wrong, and then next thing you know, you wake up and your arm feels really numb, and you're like, well, what's going on there? But, you know, you kind of have a cause there. You slept on it wrong, you cut off blood flow, you took it, and it went away. But it can be mild. That's why you don't necessarily, I would implore everyone to seek out that medical care, because, you know, you don't want to be the one that's actually making that decision. Let the physician be the one to assess and figure out whether or not this was really a TIA. So they can be more mild, but they are usually mirroring what we would expect to see in a stroke.
Okay, related question, and you've answered in part, get it checked out, but what can be done if a person has a TIA to prevent stroke?
So one of the things that happens when you do, if you were to come into the emergency department and you're diagnosed with TIA, there's one of two things that are going to happen. They either A, say, you know what, you're a high-risk patient for stroke, and we know that there's a large percentage of patients that when they have a TIA will go on to have a stroke. We may have to admit you to perform a full stroke evaluation. And that'll involve CAT scans, MRIs, assessment of different arteries, both in your neck, called your carotids, an assessment of all your risk factors, everything from your weight to your blood pressure to your cholesterol, and just see what can we modify immediately because we've identified you as a high-risk person for stroke. Now, if you're a low-risk person, there are actually ways to care for patients on an outpatient basis, doing the exact same kind of workup. But because you're lower risk, you know, maybe I only have high blood pressure, but I'm otherwise fit. And, you know, at that point, they may decide to do the workup on an outpatient basis. But either way, the main focus for a TIA is, number one, make sure it wasn't a stroke. And then number two, assess all of the risk factors and try to aggressively modify them so we can prevent a future disabling or even lethal stroke.
Thank you. Dr. Barreto, again, another question on TIA. You spoke about what may happen in the days following a TIA and then a little bit longer. Question here is, what happens further out in time from a TIA? Are there data that speak to increased likelihood of a stroke down the road, or after you get past that sort of mid-frame time, does it just dissipate?
Yeah, so a lot of the data looks at 30, 60, and 90-day, cause, increased risk of stroke, and it tends to increase over time. I believe in the slides we had a 5%, 5% of patients that went on to full stroke, and after a while, once you get past 90 days, you essentially begin to adopt your stroke risk as it relates to your modifiable risk factors, and you kind of remain at that level. So you're at an elevated level, especially if you don't do anything to change your risk factors. If you actually have a full stroke, your chances of a recurrence of stroke actually increases as the time moves on.
Last question, I think, on TIA. Would your blood pressure be elevated if you have symptoms of TIA?
So that's kind of chicken or the egg. Sometimes you have high blood pressure, which leads to a TIA, which can lead to a stroke. Sometimes you have a TIA, and because you're stressed, nervous, your blood pressure can go up. It can be a little bit difficult for the physician to figure out sometimes, but you kind of weed your way through it, gain a little more time to figure out how things are going, as well as talk to the patient. Have you taken all of your medications? Like, no, doctor, I've missed it for the past week. Well, then I probably have an idea that, this blood pressure probably came first, and the TIA came next. So it really just depends, but usually when I have a TIA patient, they also have high blood pressure.
Going back to the TPA issue, can TPA be administered for a second stroke to someone who's already received it for a first stroke?
So we have a checklist that is followed very, very strictly for all TPA patients. One of the things that kind of pulls you out of the mix to be able to receive TPA is what we call an abnormal CAT scan. So previous stroke would fall into that category, and the reason that you wouldn't be able to receive the TPA is you would be at an increased risk for bleeding inside your brain secondary to the TPA. So we don't want to, this is what we call the risk-benefit ratio, so we don't want to actually cause more harm than good in this instance, and we would not administer TPA in someone with an abnormal CAT scan.
Okay. I know I'm firing these questions at you because they're coming in.
Yeah.
Quick
This is fun. I like it.
Good, good. Is it unusual for a 3-month-old to have strokes leading to seizures, and what would cause that? And unfortunately, this listener says my child is now at Mount Washington Pediatric Hospital.
Well, first, of course, very sad. My prayers to the family. And the general question, I'll expand it to all pediatric strokes. First of all, extremely, extremely rare for this to occur. Usually, there is another disease entity involved. One of the more common ones is something called Kawasaki's disease, which happens in pediatrics and can lead towards stroke. Of course, COVID is always a consideration now, and that's not one that I had to consider in the past. I don't know that it would necessarily apply to a 3-month-old, but that's one that comes into our list now. And then there are a couple other rare childhood diseases that cause strokes secondarily due to a function of either bleeding clotting disorders or disruptions of the arteries within the brain.
So low-dose aspirin, you spoke about aspirin earlier, and someone says, I really can't take low-dose aspirin because of the side effects, stomach pain, etc. Are there other options? And then you just throw something in. I thought I heard something this week about the same effect from low-dose aspirin and regular aspirin. I'm not sure whether that was related to stroke or heart disease.
Yeah, so actually one of the more common problems that we see is tolerance of aspirin. So when you have, so first there are a couple different ways to get around this. The first is exactly what you talked about, Donna, which is make sure that you're on the right dose of aspirin. The very lowest dose, which can be as low as 84, 85 milligrams per day, often gets you around the effects on the stomach. But even if that is still a problem, and I'll put a caveat on this. You, again, do not do this unless you are at the direction of your physician, and it is often not done unless you're at a high risk. There are some medications, antiplatelet medications like Plavix, that can be administered instead of aspirin, which doesn't carry necessarily the GI upset that may make aspirin intolerable.
Does hydration play a role in preventing strokes?
I mean, I can make some connections there, but for the most part, if you're getting dehydrated transiently, that's not going to necessarily lead to you clotting or increase your chance of clotting. Now, if you're so dehydrated that you impact your kidneys and cause high blood pressure or do something to that effect, there's an extreme where, yes, that comes into play. But for the most part, if you're exercising or you work throughout the day and you forget to drink some water, not the best thing. I mean, you want to stay hydrated, but you're not necessarily increasing your chance of stroke.
Here's a softball. What's the best way to identify if a hospital is stroke designated hospital?
So the best way to notify, now I feel challenged because this is supposed to be a softball. So almost all the hospitals will have this well-designated, across their websites. For the most part, most of your acute care hospitals will be, stroke centers. But I actually am not 100% sure of that statement, so I do want to put an asterisk by it. There may be a hospital that doesn't have that capability somewhere in the state of Maryland, but I think for the most part, it would have to be a very small hospital that didn't have that.
But your EMS providers would know, as you said.
Oh, well, that's it. So I guess the answer to the question is you don't have to know because your EMS providers will know.
Mm-hmm. Okay, let's see. These questions start getting longer the further down we get. So I'm 76 in good health, generally. I received, and I don't know what this means, I received 25 EDRT treatments and a high dose, I get it, brachytherapy. In addition, I'm on Luprin for 18 to 24 months. Does this condition and treatment increase my risk of stroke?
So I would say that, in hearing the treatments, you probably have a condition that puts you at a possible increase for clotting, which can put you at an increased risk for stroke. But the treatments themselves are not increasing your risk of stroke. It is the underlying condition that you're treating there that may. But I would say that there's probably a larger problem as it relates to just clotting in general, and that can lead to blood clots in the lungs or in the legs.
Right, I'm going to try this question, but I'm sure I'm going to mispronounce this word, so you'll help me. A recommendation for people with familiar hypercholesterolemia.
Hypercholesterolemia? Yeah. No,
elevated
cholesterol.
Yeah, I got that part. Already on statin medication. Any ongoing research or innovations for people with these conditions?
And did you say familial hypercholesterolemia?
Yes.
Good question. So, yes, there's a couple of new drugs out there that are supposed to be more effective for this disease. And to tell everyone, familial hypercholesterolemia is a genetic predisposition towards having a much higher cholesterol level. And these patients, they start off at young ages, like as soon as it's identified. And this is where genetic testing actually can be very helpful, because you can know ahead of time with your child if you have it. You can expect to find it expect to look for it in your children and get therapy started earlier. But you can end up seeing, very high cholesterol levels in 15, 16 years old, which you just normally never see. And we usually see elevated cholesterol levels, and I'll use and tell my story. As I hit the big 50 this past year, I checked my cholesterol levels, and you know what? They've inched up. And I had to batten down the hatches. I had to get on the bike more. I had to eat, less of my favorite foods, that may be fried or whatnot. So, but familial hypercholesterolemia starts at a very young age, and you're essentially born with it, and then there are medications that work very well towards controlling that.
Question about COVID and its relationship here. Have you found incidence of stroke to be elevated after COVID-19 vaccine administration? Is there a mention?
Happy to discuss this as well. So when you talk about COVID vaccine, of course, we have 3 different COVID vaccines. One from Moderna, one from Pfizer, one from J&J that are currently being used. The one that has made the headlines is J&J, and it was paused for a brief period of time because of some clotting disorders, and that has had some blood clots actually inside the brain. It's not quite the same because for a stroke, it happens on what is the arterial side. So arteries take blood to the organ, and then veins drain the blood out from the organ. The J&J vaccine has caused blood clotting on the venous side, which has caused some problems in those patients, although rare, and rare enough that it was considered still safe to administer. There are reports of stroke with that J&J vaccine, and the messenger RNA do not contain that risk profile as it stands right now.
Thank you. So there's a very technical question here. It doesn't relate to stroke specifically, but it relates to freestanding medical facilities and observation beds and Medicare and the requirements for skilled care. So I'm going to leave that one for offline if we might, because it's not a stroke question, and we are running up on time. So here's a great question. I think it's important for all of our listeners. If you witness someone having stroke symptoms, should you give that person a low dose or any aspirin while waiting for EMT?
So unlike a chest pain patient where we do want you to basically get that aspirin in as soon as possible, and really you shouldn't be administering any medications unless it's at the direction of a physician or EMS. The danger part about a stroke and doing that is you don't know yet whether that is one of the 12% that is actually a hemorrhagic stroke. And if you give someone with a hemorrhagic stroke aspirin, you're actually going to make the situation worse. So keeping it simple, stroke symptoms, 911. Do not administer aspirin. Don't try and administer any therapeutics. Just get that patient to the emergency department.
Thank you for that. And then maybe a final question. Someone's asked about factor V.
Oh, factor V Leiden, maybe?
Factor V Leiden, yes. So yes. This person said their daughter had a stroke at a very young age after going on the pill, and I wish everyone were tested for factor V.
So you're bringing up, this is a great one to land on because factor V Leiden, as well as other, and then let's expand it to any blood clotting disorder. Anything that makes your blood clot is going to make you at risk for stroke. Factor V Leiden is a little bit more, it's one of the more severe ones. And birth control pills also increases your risk for blood clotting as well. So if you have that Factor V Leiden plus that, yes, that is not a good combination and can increase your risk for blood clots. And then another risk factor, so again, I told you about veins and arteries, right? Well, in the heart, you have the right and left side of the heart. One part that handles the veins and takes in the blood, and then the left side that pushes out the blood. The only way you get a clot to start on the venous side, which is where it usually starts, and travel to the artery is through a hole in the heart called, and the name is not important, but a PFO, patent foramen ovale. So that hole in the heart which some of us are simply born with, and it's small enough that we never notice it and none of it affects us until a blood clot is formed and it travels. That's actually one of the things that we do to evaluate people for stroke is, do they have that small little hole in their heart that we have to look at? Because young people, and you know, the daughter that is described here, and for those New England Patriot fans, Teddy Bruschi, the linebacker, and at a very young age of 30, I think he was in his 30s, ended up getting a stroke. He had a PFO. So he had a blood clot on the venous side that traveled and went across to the other and caused a stroke. So that is a way that it happens in younger people, and one that we are aware of and that we work diligently to try and identify. And in fact, 5 Leiden is a genetic and a blood clotting disorder that we are still learning about, and hopefully we get to that ideal state where we're able to identify everybody with that disorder as fast as possible for all the reasons that was just described in that question.
Well, Doctor, thank you for being so patient and answering all of these questions that have come in. I do have a really important note here for you, and it says, happy birthday, Doctor. So happy birthday from all of us. And for everyone who's watching and listening, thank you so much for joining us today. In about 48 hours, you can go on to www.ums.org/Let's Talk, and you can see a replay of today's session and view any of these slides that you might like. And also there, you'll see them listed. All of the prior topics that we've discussed in the last year or so will also be up there for your viewing should you like. Please do join us. We have one more session coming up in June, and then we'll be off for the summer. We're going to be talking about skin cancer in June, which many people think doesn't affect them, but it can affect almost anyone. So join us again, third Wednesday in June. And again, Dr. Barreto, thank you so very much for your expertise, time, talent, and willingness to talk to us. And thank you all for joining us.
Thank you for having me. Wonderful to talk with everyone. I hope everyone was able to learn a little something from it. And if we can just affect one life, it was well worth it. I wish everyone the best. Be healthy, be safe, and thank you for having me.